All right. Thank you guys for coming. I'm going to be talking about phantom limb pain today. So, kind of an overview. Essentially, what phantom limb pain is, it's perceived pain from an amputated limb as if it were still attached to the body. And it's really an enigma. It's really a mysterious and puzzling question of why it happens. And we're starting to understand some of the mechanisms behind it, which I'll get into a little bit later. But it's still a very convoluted and not very well understood as far as treatment goes in treating this condition. So the estimates are that 60 to 80% of patients actually experience phantom limb pain. Now, with that being said, only a portion of those are actually severe. With, you can see the percentage there, 5 to 10%. But there's another sensation called phantom limb sensation, which is essentially sensation or feeling like you still feel a limb or the presence of a limb there, which happens in roughly 100% of patients that have an amputation. Now, it doesn't happen throughout the whole time. It may only be for one point in time, but there is an incidence of at least some phantom limb sensation in almost every person that does have some kind of amputation. Now, some of the things that kind of change the incidence of phantom limb pain is if you have a higher amount of pre-amputation pain on the limb, so if your pain is greater in the limb before it gets amputated, you are at an increased risk for developing phantom limb pain. And that kind of goes the same with how long you've been having pain. So if you've been having pain in this limb for years as opposed to 3 months, you are going to be at an increased risk for developing phantom limb pain. Some other generalized information about phantom limb pain is that, it can be continuous or paroxysmal, which essentially means that they can have pain all the time or it can wax and wane. And one of the things that is understood about it is that typically with time, the pain does get better. Now, the pain can be described many different ways. You can see the descriptors: tingling, throbbing, piercing, pins and needles. It can feel pressurized. It can come in all different types of descriptions. And there's some different things I'll talk about a little bit later about how we can kind of prevent it with perioperative or postoperative neural blockade. I'll get into some studies a little bit and talk about maybe ways that researchers are trying to prevent this from happening, since it is such a high incidence. And on that point, since it is such a high incidence, it's really crazy that we don't have a whole lot of good studies for treatments. I will talk about some treatments, but really there's no first line pharmacologic treatment for this. It's kind of trial and error to see if it works, because there's no studies that definitively say that one agent works. Everything says, some studies say that it works, some studies say that X agent doesn't work, and I'll get into that a little bit later. And as far as bilateral versus unilateral, there has been no significant relationship between having one amputation versus two in the incidence of phantom limb pain. Your risk is about the same. Doesn't really matter if you've had one or two. So the pathophysiology, there's really 3 different speculated mechanisms with how this happens, which I'll talk about independently, but they essentially are peripherally and centrally. And centrally is split up between the spinal cord and brain. So into the development of phantom limb pain, it is a very intricate process, which I'll try to explain the best I can in the next couple of slides. So first, I'll talk about the peripheral mechanism. And essentially what it is when you have an amputation, obviously what you're doing is you're not only severing bone and skin, but you're also severing a nerve. And what this does is it disrupts the normal afferent nerve input patterns to the spinal cord. And what happens after that is you actually have deafferentation, which is essentially an interruption or disruption of the afferent connections of the nerve cells, and you develop neuromas at the proximal portion of the severed nerve. And you can see here, the neuroma would be right there, where you can see that it's actually a congregation, or it's a congregation of your nerves, and they kind of form together to develop what we would call a neuroma. And what happens is that in these neuromas, there's an accumulation of molecules, which enhances the expression of sodium channels. And what this causes is hyperexcitability, and especially in the afferent C fibers, and spontaneous discharges. So this mechanism has nothing to do with the central nervous system, but when you do have an amputation, you do develop neuromas, which can have their own kind of spontaneous discharges at causing pain. Now, one thing that this doesn't explain is congenital absence of limbs. People can still have phantom limb pain even if they do not have the limbs. For instance, I read one study where a patient actually was born with 4 fingers and had to have that hand amputated. And through studies and through different treatments, the patient was actually able to feel 5 fingers, even though she never had that 5th finger. And it kind of goes into explaining that this is not the only mechanism. This actually isn't the most thought mechanism to be most influential in the development of phantom limb pain. The next one I'm going to talk about is the central mechanism for the spinal cord. And essentially what happens when you sever a nerve, the axonal sprouts at the proximal section of the amputated peripheral nerves, they form connections. And what happens is they kind of change their connections in the spinal cord. The non-pain transmission nerves essentially start to sprout into the lamina 2 of the spinal cord, which is essentially responsible for pain. And what happens is there's increased neuronal activity here, there's expansion in the neuronal receptive field, and you get hyperexcitability again. And another thing this leads to is central sensitization, which I will talk about a little bit on the next slide. After the central sensitization and wind-up phenomenon, which is essentially upregulation of receptors leading to a change in the firing pattern of the central nociceptive receptors, you have a loss of descending inhibitory transmission, which means that it's hard to turn off the pain response. So talking about central sensitization, I'll talk about it a little bit. And there's a great article down here at the bottom right from 2009, which goes into it in much more depth than I'm going to talk about. But essentially what central sensitization is when neurons' resting membrane potential changes to a lesser threshold towards the depolarization threshold. So what that essentially means is that it's much easier to have a pain response sent out than normally. And it's usually caused from chronic pain that's ongoing over a long period of time. There's not one single defining molecular mechanism that leads to central sensitization, but there is quite a few proposed mechanisms. And one of them that is most thought to be associated with is increases in intracellular calcium, and in particular with glutamate receptors, the NMDA and the AMPA glutamate receptors. And what happens is they become phosphorylized, and that leads to central sensitization. Typically, in patients that don't have central sensitization, when they become phosphorylated, they can be dephosphorylated from different phosphatases. However, when patients undergo pain for a long period of time and they start to develop central sensitization, transcription changes actually occur which prevent that dephosphorylation. So these NMDA and AMPA receptors actually become phosphorylated and not able to become unphosphorylated. So they're kind of stuck in this position where they're at an increased, they have an increased response to pain, essentially. So the last one, and the most, this is the one that's probably best studied, is looking at the central mechanism in the brain instead of in the spinal cord. Now, before I go into this, it's kind of important to realize how the brain detects stimuli and pain. So for instance, when someone touches your hand, a signal gets sent to your brain recognizes and interprets it, and then you feel the sensation. When you lose a limb, you're no longer able to send signals to that part of the brain. So for instance, your hand has a certain part in the brain which responds to sensation when you touch your hand. When you no longer have a hand, you can no longer receive sensations to that part of the brain. So it's going to be what I'm going to call like a brain dead zone. As a result, the brain is how we know now. There's neuroplasticity in our brain, which essentially means that it's like plastic. It can be molded, it can change, which is relatively new within the last probably decade or 2 decades. We've started to realize that the brain can change in these different ways. So what happens when you have this dead zone in the brain, the active parts in the brain can actually hijack the dead zone and to make it its own. So for instance, if you lose your hand or for instance, below the elbow amputation, there's 2 things that can happen. For one, depending on what part of the brain it affects, essentially the part of the brain that could take it over could be your bicep or like shoulder down, or it could be your face. Your face is closely interpreted with your arms and hands, or it's in a close proximity to the brain. So what happens is that the brain can actually start to interpret pain touching as like touching your arm as pain in your hand or feeling in your hand, even though you no longer have a hand. And that's due to this neuroplasticity and essentially hijacking of your brain, taking over spots that no longer works. And that's kind of what cortical reorganization is. That's the whole process of cortical reorganization, is your brain kind of changing because you no longer have a limb, you can no longer receive sensation. So other parts of the brain are going to take that part over. Is there any questions so far? Okay. So as far as risk factors, there's been some that have been studied. So as far as overall, upper limbs are more likely to occur than lower limbs. Females are more likely to develop phantom limb pain than males, and that is not only with the risk, but also the pain intensity and the interference with life. Females typically have it worse off more than males. As I mentioned a little bit earlier, pre-amputation pain and residual pain, these are two things that also are risk factors for phantom limb pain. If you are in severe pain before your amputation, your risk of phantom limb pain actually increases quite a bit. And then that residual pain as well. As far as time after amputation, or it should really be time before amputation, really depends on how long you've been having the pain. Increases your risk. And then other psychiatric conditions, which this is kind of debated, but typically what we think about is like stress, anxiety, depression. We know they have a very close influence with pain, and they kind of work hand in hand. So when patients have these conditions, it is speculated that you are at an increased risk for developing phantom limb pain. So the first thing I'm going to talk about is prevention. So unfortunately, with pharmacologic treatments, we don't have a whole lot of good data, but we are starting to find good data, at least in preventing. So one way that they're actually looking at preventing is using a continuous peripheral nerve block, which the study I'm going to talk about used a continuous infusion of ropivacaine, 0.5% at 5 milliliters per hour. And they continued that for 4 to 83 days after surgery or after the amputation. During that time, they were assessed several times where the infusion was turned off to see if the sensation returned and seeing if they had pain. And if they didn't, they would keep it off to see if they continued to not have pain. And if pain came back, they would continue throughout the 83 days. You can see the percentage of patients with the VRS pain scores, and you can see that no patient had a pain score of actually 4 at the end of 83 days. And you can see most patients had a pain score of 0. So what this really says is that there are ways to prevent it, and it could really change the way we do surgeries and postoperative care with surgeries. There still needs to be more research done in this area, and it still is getting done, which I'll talk about a little bit more when we actually start talking about treatments in the non-pharmacologic way, how this could actually be beneficial in patients as well. So as far as pharmacologic treatments, unfortunately, there's lack of studies for both pharmacologic and non-pharmacologic treatments. Many healthcare professionals therefore use a similar algorithm to treating phantom limb pain as they would use to treat other neuropathic diseases like peripheral diabetic neuropathy or fibromyalgia. One thing that's commonly jumped to first is acetaminophen or NSAIDs. And unfortunately, there's really no studies to look at using these agents in phantom limb pain. Some people say that they do help, but there's no good studies saying that this actually works. As far as opioids go, there have been some studies, and the opioids that have the best data are oxycodone, methadone, morphine, levorphanol, and tramadol. And what they found is that these agents actually treat the phantom limb pain better than TCAs or gabapentin. As far as TCAs go, it's recommended to use nortriptyline or desipramine, and that's just due to the fact that the other ones, amitriptyline, have more anticholinergic side effects. You're going to be more worried about sleepiness, changes in mental status, stuff like that. So the TCA is kind of the mechanism how they work is they inhibit serotonin norepinephrine uptake. They also have some NMDA receptor antagonism and sodium channel blockage. So as I mentioned a little bit more, the NMDA receptors is part of central sensitization and is also part of the development of phantom limb pain, or at least is speculated. So this is kind of their route. As far as the SNRIs, there's very limited data. There is a little bit of data with duloxetine, and there's been at least one case report in patients using duloxetine and having benefits of their phantom limb pain. Another big area for treatment of these agents is the anticonvulsants. So a lot of times we'll think about this in neuropathic pain. So gabapentin, carbamazepine, oxcarbamazepine, and pregabalin. Gabapentin has actually shown mixed results. There have been some small studies to show benefits, while others don't have any benefit at all. So it's really hard to say whether it's going to work for your patient. And as I mentioned before, this is going to be an area where you kind of have to do trial and error, along with many other pain conditions. It's just kind of the way that this is set up right now for the treatment. Carbamazepine has been reported to reduce brief stabbing and lancing pain, but hasn't really been shown to reduce any other pain so far. Oxcarbazepine and pregabalin have very little data, minimal, if any, that I could find. As far as calcitonin, this was somewhat unique, and many professionals wouldn't jump to this agent, but from what I found, it really only has use in one area, and that's if patients develop heterotrophic ossification. So essentially what heterotrophic ossification is the growing of bones in areas where bones typically do not grow. There has been data to show that, especially if you have an amputation, you start growing bones in an area where you typically don't, that calcitonin can help reduce pain and can help reduce phantom limb pain in patients that do have this. Now, this is a relatively rare condition, with I think one study referenced about 5% of patients have this. But if you ever do have a patient with phantom limb pain that has been diagnosed with heterotrophic ossification, calcitonin could be an agent that you could try to help reduce the pain. As I mentioned, the NMDA receptor antagonist could be beneficial because it's thought they could have an influence on the development or preventing the development of central sensitization. So one of them that I'm going to talk about is memantine, which is an NMDA antagonist, although it's not really clear if it works. Really, the speculation is that if it is going to work, it's going to be most useful soon after amputation, when you're going to be at the highest risk for developing peripheral phantom limb pain. So memantine's one option. Dextromethorphan and ketamine also work on the NMD receptors, and they have mixed results. Again, with the other agents, some of them say that they work okay, some of them say they don't. And ketamine's really unique because there's been at least one case report of ketamine actually inducing phantom limb pain in addition to causing visual hallucinations. Now, we know that ketamine has a bunch of adverse reactions and associated ADEs with it, so it's going to be something that isn't used commonly, but there has been some research to say that it does help some people. There's been other studies looking at propranolol and nifedipine. However, those studies were not very well. Actually, almost every one of these studies that I'm talking about and I have referenced, they weren't powered. They don't have enough people, which is really surprising to me with the actual occurrence of this condition, that there aren't more good studies out there to look at treatments. And maybe that this is just a condition that pharmacologic treatments aren't really the best option. Non-pharm therapies may be better than pharmacologic therapies, which I'll talk about on the next slide. So some of the non-pharmacologic treatments in treatment of phantom limb pain. One of them is TENS, or transcutaneous electric nerve stimulation. So there's been some debate about the most beneficial spot to put this. So if you have a below the knee amputation, would it be beneficial to put it on that side of the leg, or would it be put it on the other side, which we'd call contralateral? So there's been some speculation that TENS may actually exacerbate pain in individuals with tactile allodynia, which essentially when you touch or have a sensation that causes severe pain that typically wouldn't cause pain. So there's been some speculation that maybe if you put it on the same side that has been amputated, that you're going to increase that and you're going to actually cause more pain than you're going to help. There's also some fear that TENS may cause skin irritation, which may affect stump integrity. So it is known that the stimulating sensory afferent neurons can generate sensations of touch, joint movement, and position of the phantom limb of amputees. So essentially what there has been research done with TENS, there's been research both on ipsilateral on the same side of the body and contralateral. And I couldn't find one was better than the other. Studies kind of both say that, this one's okay and this one's okay as well. But one thing that I found interesting is that if you do put it ipsilaterally on the same side, and if they have a prosthesis, you can actually trick the brain into thinking that they're having sensations down into their foot or their leg, where they're actually going to feel like they have their foot or their leg, which kind of goes into this whole treatment of phantom limb pain. Really, in my opinion, and the research that I found, it's not really about treating the condition and as much as it is retraining your brain. Really, from what I understand, it's that the brain kind of gets out of whack because it's still getting sensations from other parts of the body because it's been taken over or hijacked by the brain, at least the dead zone in the brain. And we really have to retrain our brains to kind of fend for itself in that dead zone to kind of help prevent other stimulation from causing pain. So the TENS, it can be used either contralaterally on the other side of the body or ipsilaterally. Another therapy that's used really often and has been shown to be beneficial is mirror therapy. So mirror therapy is thought to be beneficial by resolving the visual proprioceptive dissociation in the brain. So it essentially helps to trick the brain into thinking that there is a limb still there. Now, to perform mirror therapy, a patient will typically watch the reflection of their intact limb moving in the mirror. So for instance, if you're looking at me, I would put a mirror right here in between me and have my hand on this side if my left hand was amputated. So here is a mirror, and I'll put my hand over here. Now in the mirror, I will be able to see this hand, but it will appear as it is over here. So I would put either my stump or my amputated limb in this side, and I would try to move both or pretend that I'm moving both. And in the mirror, it would appear that I'm not only moving this hand, but I'm also moving this hand. And what that helps to do is kind of helps to trick the brain and think that there is a limb still there, which has been shown to actually reduce phantom limb pain, which is something that is somewhat interesting. Another thing that they're starting to look at is spinal cord stimulation, especially with dorsal root ganglion stimulation, which has been shown to have some beneficial data. And I'll talk about it a little bit more on these next couple slides with how it has been beneficial. So there has been a case report of phantom limb pain in the hand. This patient had years of suffering with no treatment that would work. They did pharmacologic treatments, it wouldn't work. There was really nothing that was really beneficial. So what the physicians decided to do, actually their pain was a 7.6 out of a 10 on the visual analog scale. He used dynamic arm prosthesis, but didn't have any benefits. He also tried mirror therapy outside of pharmacologic therapy and only had slight benefits from mirror therapy. And he stopped soon after, which the benefits went away. So the brachial plexus block was performed for 6 hours. And after the anesthesia wore off, the patient no longer had pain. Now, these years of suffering, it wasn't only pain that you would typically think of phantom limb pain, such as, the tingling, the sharp pain. He actually had a cramping pain too. So he felt like his hand was cramping, even though he didn't have the hand there. So they did this brachial plexus block, and what they found actually is that the cramping feeling had completely resolved after the 6-hour infusion. There was no more cramping feeling. Not only that, but peripheral or the phantom limb pain and phantom limb sensation had dramatically reduced. So they did brain imaging and actually looked at the cortical reorganization and the distance between, I'm not sure exactly how they did this, but they essentially found that after the 6-hour infusion that the brain had reorganized itself in a way. You can see here that the pre, the post, and the post one, and the Euclidean distance. So the pre, you can see that they were very similar. You can see the distance between the 2 points actually decreased, which essentially says that the brain reorganized itself to become less dependent on that brain dead zone that I was talking about earlier. There was another crossover study with an N of 3, which used perineal ropivacaine or normal saline. So it was a crossover. They did one medication, then 4 months later, they would come back and do the other medication. And what they found is that actually only 2 patients completed the study, but what they did is they had a portable infusion electronic pump, and they did it for a total of 6 days. So both patients in this study actually received normal saline first just by chance. And after their infusions of 6 days, they had little to no relief. After the 4-month period when they came back for their ropivacaine, one patient experienced phantom limb pain, but it was at a fraction of what it used to be. It was at they typically had it at 7 to 8 pain. It was down to a 3 to a 4. So they've significantly reduced the pain from this 6-day infusion. And then the other patient had no pain at all. Their pain completely dissipated. Prior to this, they did both have severe pain. Now, with that said, there has been at least one case report of a 29-year-old amputee who developed phantom limb pain after a femoral nerve block. So not to say that there's not risks associated with this. There's still the risk especially when you're talking about nerve blocks and getting into the spinal cord. I mean, it's a scary process, but this isn't without saying that there is still some risk associated with it. The last thing I'm going to talk about is something new and kind of upcoming, but it's actually looking at virtual reality. So this kind of goes with the mirror therapy, just a little bit more in depth and a little bit more futuristic. So they actually looked at 8 different people who had upper limb amputations. And what they did is they'd put on these devices, virtual reality, to cover their eyes, and it would appear as though they had both hands. And what they would do is they would have one hand or one arm that still had function and wasn't amputated, just draw lines. And then on the other hand, in the virtual reality, they would just have them doing circles at the same time. And what it really did is it helped for patients to kind of change their brain, like I said, with the neuroplasticity and how it is thought that phantom limb pain comes, that they experienced significant pain relief. You can see here 39 to plus or minus 28%. Some patients might not have had very much, but some patients had an extreme amount of pain relief. And I think is with the research right now that phantom limb pain, one of the best treatments we can do is non-pharmacologic. And I kind of think that goes with all aspects of medication. We would like to do non-pharm before pharm, but the pharmacologic treatments for phantom limb pain just don't have a whole lot of good data. If I were to start something, I would typically probably do something that you would do with any neuropathic disease. You could try gabapentin, you could try anticonvulsants, and just see if it works. There's not one agent that has a ton of good data. So with that, that is the end. This was somewhat of a short one since there isn't a whole lot of good data, but any questions you guys may have, I will be happy to answer or try to.
Hi, Brad. This is Matt Hammer. Can you hear me?
Yes, I can.
My question was, with the first study you talked with the ropivacaine with the 83 days, did they say why they picked 83 days, or is there something I'm missing on why it would be that long?
So
and maybe you don't know.
I don't know exactly, but my speculation is that they didn't have to be continued for 83 days. It really, they would check it at week 1, week 2, week 3, and then they extended out. And if they took off, because they would stop the infusion for the sensations to come back, and if they didn't have any phantom limb pain, they would stop it at that point. So I think the 83-day mark was like the max they would go as far as seeing if this infusion would work and preventing the pain extended. But many times the average duration was only about 30 days that the patients were on this continuous peripheral nerve block. And after that, you can see by the number of patients who had low pain scores that most patients were without pain at that point.
Okay, thanks.
Yep.
Brad, did you see much data around the use of topicals for phantom limb?
I've seen some data looking at capsaicin, getting rid of substance P. It wasn't very good data. It was kind of like all the other data I found. Nothing really seems to be definitively beneficial. I didn't see anything about any kind of NSAIDs or any other topicals, no. But capsaicin is the only one that I've actually seen that had at least studies with it.
Thanks.
Yep. And then just for clarification, as far as the TENS unit, the way they want to do it is they want to stimulate the nerve that actually goes down in the amputated limb, which is hard to do, especially for someone sitting at home doing it themselves. So. Oops. Okay. Well, any other questions?
Man, it's a quiet crowd today, huh?
Yeah.
There's one that says classroom on here. Is that Michelle Matthews' crew? They might have just logged in and then all left and gone to lunch.
Oh, I'm excited for lunch.
Yeah, me too.
Getting Thai today.
Are you really?
Yeah.
Oh, man.
That's unacceptable, Brad. Can you just get it and bring it to us in Edwardsville, please?
Yeah, I can.
Julie, have you been to Zap Thai yet?
No, and I had some pad thai at another place the other day, and it was just not as good as our other place. Where is the Zap Thai?
So do we have any more other questions? Because we should stop the recording if we're...
Oh, look at Brad being all professional.